So welcome to Life on Life's Terms, episode 42. We have Dr. James Shapiro in. He is in the studio today. He is accredited with making the Edmonton Protocol for human islet transplantation. He's currently continuing this research, and he's also in research with stem cell therapy. So basically what we're going to be getting into today is diabetes, islet transplantation, stem cell theory, or stem cell research. And we have Dr. James Shapiro here. How are you this morning?
Great, Justin. Thank you very much for inviting me.
How has your week been so far?
It's been varied. I have been in surgery most of the days this week, doing complex surgeries of various types. And it's actually a pleasure to get out of the hospital for a moment and see a bit of the city.
Excellent. So I guess I'm going to start off with the last thing that I saw of you on YouTube was actually the Google thing, like the Google speech that you had. How was that experience for you, going to Google and speaking?
That was a really interesting endeavor. I was excited about it because Google had expressed an interest in diabetes. They have many people that work at Google, of course, that have type 1 and type 2 diabetes, and they had developed a contact lens that could go on the front of the eye and measure the blood sugar in a non-invasive way. So I was excited to be invited to go there and give this broadcast, and also meet with the Google Glass team that makes special glasses where you can monitor information on your glasses. That was a really remarkable visit that day. And I was surprised how widespread that video ended up being. It was very useful. I
think last I saw 17,000 views on that video alone, which is pretty spectacular. And when you were talking about the basically the artificial intelligence behind that glass to be able to know our biome was very interesting to me. I thought that was pretty interesting, and to see that. Well, actually, Elon Musk just talked about something, how he's trying to change the bandwidth time from our minds to our ideas because our thumbs are just too slow with phones. So I think that kind of goes along the line of what Google is doing, and it's pretty interesting to see how much our minds are changing with almost like this androidic thing that's happening, right?
Well, the bandwidth thing is a really interesting thing. You know, we have in front of us laptop computers here with QWERTY keyboards, and then we're busy tapping with our thumbs on the phone. It is a very inefficient system, and I'm a particularly slow typist, and I'm very slow texting on the phone. My wife's always laughing at me. If we had better bandwidth between the interface better with our computers, it would be and phones would be a lot better off. And the voice recognition today is it's fairly appalling to me. Like, trying to get here today and put your address in the system and get here on time was it was too much for Siri and too much for Maps. So there we are. So we've still got a long way to go with the technology.
So let's get into islet transplantation transplant for the listeners. What, in case they haven't seen video, I'm sure a lot of the listeners, because you were voted in as the most popular doctor to come in on the show, I'm sure a lot of them have seen videos, but for those who haven't seen videos, what is that in its most basic form, if we can go there?
Sure. So maybe we should start with diabetes and what that is.
Okay, sure.
Assuming that people might know it but might not. So diabetes is an illness, a condition where the body loses its ability to regulate the blood sugar. It's very important to keep the blood sugar in the normal range. If blood sugar goes too high, then complications happen over the course of time, often many years. It damages the blood vessels. The little micro blood vessels that supply the back of the eye, that supply the blood vessels to the leg, and critically supply the brain and the heart, all get damaged. So as a result of that, blindness, strokes, heart disease, amputations, kidney failure, need for dialysis, and early death are all, unfortunately, what happens to patients that have poorly controlled diabetes over a long period of time. And there's two main types of diabetes, actually many smaller different types. I won't go into all of those to make it too complicated, but basically there's two main types of diabetes. Type 1 diabetes that generally affects children and adults, many children diagnosed in childhood anyway, where the immune system attacks the cells inside the pancreas, an organ that lies behind your stomach. And inside that organ are the cells that make insulin. They're called islets of Langerhans. And the immune system attacks the cells inside there, the beta cells that make insulin, and your body can't make any more insulin. In type 2 diabetes, at least at first, the pancreas continues to make insulin, but the receptors on the rest of the body that take up the insulin and act to lower the blood sugar fail. So in patients with type 2 diabetes, the people become insulin resistant, and then eventually the pancreas burns out. So in both forms of the disease, they end up with poorly controlled diabetes. Now, we're almost at 100 years since the discovery of insulin by Banting and Best. And insulin is a life-saving treatment. It's given by injection. It's given injection under the skin. And patients with diabetes have to take many different injections a day. They have to take long-acting insulin, usually twice a day, sometimes once a day. And then they have to take additional short-acting insulin every time they eat. And the idea there is that when the body can't make its own insulin, that this will be life-saving. However, it still is far from perfect. When you inject insulin under the skin, it sits there in a little reservoir and is slowly or rapidly absorbed, but nothing like the instant that the body would normally function as. So if you have, if you don't have diabetes, you have normal pancreas. When you eat a chocolate bar or you have your breakfast, you can make insulin immediately to keep your blood sugar rock steady in the right range. When you have insulin injections for diabetes, your blood sugar still bounces all over the map. In some people it's reasonable, in some people it's wild and extreme. And in the patients where it's wild and extreme, we consider them for this cell transplant treatment called islet cell transplant, or the Edmonton Protocol, where we inject human islets that come from organ donors. We extract them through a very complex process in the lab from human pancreas organs that are shipped to us from all over the country. That process involves a team that work day and night, and usually night. And it takes them 7 or 8 hours to do that. And then they prepare the cells. They put them in an incubator for usually a day or two once they're prepared. They count them very carefully. They make sure they're sterile and safe. And then meantime, we look out for a recipient who's on our list waiting for a transplant. We bring them in. We give them medications to condition their immune system so that they won't reject the cells. And then the cells are injected into the liver by a team that involves the radiologist, X-ray doctor, who places a needle in the side, just over the liver. They use an ultrasound probe to find the vein inside the liver that goes up to the liver. It's called the portal vein. Then the cells are dripped in. It takes about 20 minutes to do that cell transplant treatment. And then when they're finished, very importantly, they plug the tract to stop any bleeding or anything. And then the patient, in theory, could go home the same day. We usually keep them a day or two in hospital just to fine-tune the anti-rejection drugs and give additional anti-inflammatory medications to help the cells engraft better. But it's a very effective treatment. And even with the first transplant there, the patients have rock-steady blood sugar control. In fact, if you look at the data, almost 80% of patients have very good control of the blood sugar out to around 20 years after the transplant. We've got patients 20 years out now following the Edmonton Protocol. Now, a large proportion of patients are able to come off insulin for periods of time, but it's usually short periods of time for the first 2 to 3 years. After that, most patients have to go back, not all, but most have to go back onto small amounts of insulin to supplement the function of the cells.
Okay. So essentially after this treatment, then there's no more need for insulin for the person who has diabetes at that moment because their sugar levels are contained?
Well, not always. Around 2 to 3 years, about 80-90% of people can be off insulin completely. But the longer term, it'll fall to around, it drops fairly suddenly over the next 5-10 years or so.
That's pretty amazing, though, in the fact that it kind of almost resets that sugar level back to normality almost, I guess, after the treatment. One of the questions that I was asked by one of the listeners is, what's the difference, who has actually seen your videos, what's the difference between the stem cell and the islet transplant. Transplant.
Okay, so an islet transplant, as I mentioned, comes from an organ donor, and the organ donors are few and far between. And when an organ donor comes forward and they voluntarily agree to let their organs be removed once they've died, then we can save lives with hearts and lungs and livers and kidneys and pancreas and islet transplants. I also transplant livers as my day job, and it's a life-saving procedure for and we've done well over 1,000 liver transplants here at the University of Alberta in Edmonton over the last 25 years. A large team of people are involved with that. And so organ donation is life-saving. But in terms of diabetes, we know in the longer run there's not going to be enough organ donors to go around to treat the massive numbers of people with diabetes. It's escalating. If we count the number of people in the world right now that have diabetes, it's around 422 million people.
Wow.
Massive number of people. And the cost burden to our healthcare systems, I mean, Canada, for example, just can't afford it. Right? We can't in the longer run. So we need a better strategy to prevent diabetes and to treat it to prevent the complications. 422 million people in the world. So there were only around 30,000 organ donors last year. So there's not enough organs, pancreas organs, that come from brain dead people. So the stem cells are a way around that by having a limitless source of cells. And a long time ago that was just sort of a pipe dream that they thought perhaps it could never happen, but actually it has. So shortly after we discovered the Edmonton Protocol and tested it in our patients, I met a group in Geneva, Switzerland, who were linked to this group in San Diego that were making a stem cell that could make insulin. And I was very interested with that. They'd been working on it. They were willing to share their cells with us, and we were able to test them in our own labs. And now in thousands of mice, we've been able to cure diabetes very, very easily with these human stem cells. So where do we get them from? They came from a single human embryo that was discarded from a IVF clinic around 25 years ago, something like that. And they took a few cells from the inner lining of that, what they call a blastocyst. And from that one cell, they've been able to expand and provide basically a limitless source of cells that in theory could treat every patient with type 1 and type 2 diabetes in the world. So they're no longer constrained by the by the limitations of organ donation. So that's a really big step forward.
For sure. So
we began clinical trials with this ViaCyte stem cell about 4 or 5 years ago. We've treated around 25 people in Edmonton and also in additional patients in San Diego and now some other centers in the United States. And so far the treatment's it's very early days. It looks promising. It's certainly very safe. And we've been transplanting those cells under the skin inside a device that basically shields the cells from the immune system. We call it a macro encapsulation device. So it's a flat. Some of them are the size of a very small postage stamp, very thin and flat, made of plastic. And the larger, more therapeutic cells that contain more cells are just a bit smaller than a credit card.
Oh wow!
And we can slide those under the skin in a simple surgical procedure, and then we can take them out at different time points and see if the cells are living, surviving, turning into insulin-producing cells and functioning over time. And we're in the middle of these trials now. It looks to be very promising. It's very exciting research. And, I'm sure that this will be the ultimate answer to the supply problem for diabetes. One area that this company is working on right now, and we're fortunate to be linked with them, is in trying to shield the cells from the immune system. With the Edmonton Protocol, the islet cells that we put in the liver, we do have to give patients anti-rejection drugs, the same kind of drugs to support any organ transplant. So a heart transplant, a liver transplant, kidney transplant needs anti-rejection drugs. So these patients also have to take anti-rejection drugs to stop the cells from being rejected. In these first stem cell transplant trials that we did, that we placed those cells inside what they call the macro encapsulation device. It's called Encaptra. And this was supposed to shield the cells from the immune system. It did shield the cells from the immune system, and we even have some patients out beyond 2 years that have cells surviving without any anti-rejection drugs,
Wow.
which is impressive. but the number of cells that are surviving is actually quite limited. And the reason for that is that there's not enough blood vessels really to support the cell growth and early part of the cell survival. So then, working with ViaCyte, they made some tiny little laser holes in the surface of the device that would allow some blood vessels to come in. And that's been helpful. It has allowed more cells to survive, but at the same time, the patients now have to take the anti-rejection drugs for the time being. So it's a sort of temporary step to see if we can get more cells to survive. And then ViaCyte's also working with the company WL Goren Associates, and they make Gore-Tex.
Okay.
They're experts in biological products as well.
Oh, wow.
So we're working to see if we can find some more compatible biological products that won't need those laser holes and will allow the cells to survive better. And that might happen. And then the other approach that's happening is now gene editing using what's called CRISPR technologies. And being able to edit the genes inside these stem cells may allow them to be quiescent and not seen by the immune system, fly under the radar. So they call these now PEC-QT, and the ViaCyte company is working intensively on that. And they've also linked with a company that's doing gene editing called CRISPR Therapeutics, which I think will be, if all that works out, it'll be an amazing thing because the cells will be transplantable but not seen by the immune system. They won't be susceptible to autoimmune attack. And I think what does this mean today for someone with diabetes? It's not. I think where we are right now, it shows very early promise, but very limited, very limited. But I think down the road, the cure is there somewhere. It's out there.
And I think we're almost on this precipice of brand new healthcare, like in a capacity that, like, soon enough, like you're talking about gene editing, we won't even really know what's going on inside of our system in context of, like, sure, you take a pill and then chemically things change, right? Like you take insulin and the next thing you know, your sugar levels are now contained and you feel better. Soon enough, it's almost like we're going to be taking a pill that's going to be doing gene editing within our bodies, and the next thing you know, we don't have any of these issues any longer. It's almost like it's just gone. And I think to be on that precipice, especially in the Canadian system, like we have a lot of American listeners. And so when Americans are looking at it, we just did a debunk the Canadian medical funding. Like a lot of Americans believe that we get free medicine in Canada, and we do not get free medicine. No. So like this is what we were debunking as like the myth that it's completely free in Canada. It's not completely free. We do incur some costs as patients in Canada.
And sometimes those can be prohibitive costs. So some medications are phenomenally expensive. Yeah, that's right. We think of healthcare being free at the point of delivery, but it's maybe we're talking about the hospital care, or maybe we're talking about going to visit the physician or the emergency department or your family practitioner. But you're right. The cost of medications, unless you have a drug plan, it's a big issue.
Yeah, and Americans just think that, like, a lot of the comments that we got prior to you coming in was like, well, it must be great to live up there because all of your treatments are free, even if you don't get medicine. I said, well, how great is the treatment if you can't get the medicine? You know what I mean? Like,
well, that said, and it's right that we're always critical of our healthcare system, but I've worked in other countries, and I would say we still have a superb healthcare system.
Oh yeah,
I feel very fortunate to work in the front line of that, and doing liver transplants and other complex liver surgeries, pancreas surgeries. I realize that we work in a phenomenal healthcare system.
As well as this being Sober October, we help a lot of addicts go to treatment. So being in Canada and being able to go to drug treatment for your addiction issue is a pretty amazing experience. And that is the taxpayer's responsibility in Canada for the most part. We do have private treatment, but it's mostly used by the public sector. Like in the context, like all of our addiction treatment, the majority of it is free in Canada, and there's a very small amount that's not free. Who would be the best candidates for these treatments that you're talking about? Like if they're coming into those, like if they're coming to see you, which candidate would be the best that you would think would have the best odds for success?
So we pick patients for islet transplant that have dangerous lows in their blood sugar.
Okay.
And we get them to work with their endocrinologists and diabetes specialists to try and improve their control as best they can. And there's a handful of patients in there that, despite everything they do, they eat very carefully, they follow the diabetes regimens strictly, they take the insulin exact amounts that they need. Sometimes they use these continuous glucose monitoring technologies to help them. Sometimes they use insulin pumps to try and steady their blood sugar control and give more stable insulin delivery. But despite that, there are some patients that are at very high risk of getting lows in blood sugar. So we have very stringent criteria. We use 3 scoring systems. One is called a Clark score. One is called a hypo score, and one is called a lability index that measures the wide swings in blood sugar from moment to moment in the patient's face. And if patients are above a certain threshold, then we'll consider them for an islet transplant. We work them up, see if they're suitable. We have a multidisciplinary team that assesses them, and at that point they get listed for a transplant. Now, the stem cell transplants are a little bit different because the islet transplant we regard, and it is funded in Alberta as a standard treatment for patients with dangerous lows. So it's a standard treatment. It's been that way since 2001, standard of care. But the stem cell treatments are experimental, and they have to be. It's first-in-human trials that we're doing here, trying to push forward the boundaries of the future. And so those patients, we pick in a different way. Sometimes they are these patients, depending on the trial, like the original Edmonton Protocol patients that have risk of lows. And sometimes we've had some normal volunteers, healthy volunteers that don't have diabetes when we're just testing the devices on their own to see how compatible they are with the body. And now we're looking for patients. We're actively looking for patients for our trials. We have various trials, though. That's one of the phenomenal things about working in Edmonton. We have it, and they don't always involve the stem cells. So, for example, we have a trial now that we started about a year ago for patients that have just diagnosed with diabetes. We're hoping to move this into children eventually, but right now it's in adults. So as soon as they're diagnosed with type 1 diabetes, meaning no insulin being made, no C-peptide being made, then we give them a treatment that resets the immune system. A bit like these treatments you were talking about. You could swallow a pill and you'll change the problem, change the genetics. This isn't quite that way, but we have a medication that resets the immune system. It removes the T cells that are responsible for rejection from the bloodstream, and they help reduce the risk of autoimmunity. And then we give 3 anti-inflammatory medications to try to stop the inflammation and help regenerate and repair the inflammation and injury inside the pancreas. And then the last thing we do is we give it's called a stem cell mobilizer. And this is the clever part of the treatment. It drives out the CD34 stem cells from the bone marrow, patient's own cells.
Oh, wow.
So it's like a personalized medicine approach. It drives these cells out from the bone marrow. 1 dose of the medication spills these cells into the bloodstream. And of course, these cells, as they circulate around, they go around and they pass through the pancreas, and they target the inflamed cells in the pancreas there. And our hope is that they will regenerate and repair the injured pancreas when someone's just diagnosed. So we're excited by that. We've treated now a handful of patients. The early results look to be promising, but it is very early days. It's a randomized controlled trial. That means that we have a control group who we're not giving that treatment to. Then we have the treatment group that get these active drugs. And then there's some crossover periods. So we have some patients that didn't get it at the beginning but get it at a year. And now we're actively looking for other patients for that trial.
Wow.
And so I'm excited about that. It's a different approach. It doesn't require any cell transplants, that one. And if it works, it'll be, it could have big impact in terms of the future treatments for diabetes. Very exciting.
That is very, very interesting. One of the other this is a listener's question is, what's your personal connection towards diabetes and the motivation to continue this research?
Well, that's an interesting question. So I have no direct connection with type 1 or type 2 diabetes, fortunately. But I obviously know I've looked after a lot of patients that have it. Yeah. My interest began as a medical student when I was in Newcastle University in England. When I was 19 or 20, I started medical school. I knew I wanted to be a surgeon, and I was told that, well, if you want to be a surgeon, you should do some research. And so I went to find a surgeon, and he was called John Farndon, and he had a list of potential projects that I could work on, and I picked this one it was about transplanting islets into rats. to see if we could cure diabetes and then alter the immune system by freezing the cells. And he was a very hard taskmaster for me, but I really respected him and his partner, Tom Leonard. Worked phenomenally hard day and night. Virtually none of the experiments really worked in the way I was expecting them to, but it was my taste for research and for diabetes treatment, and I worked day and night. I worked incredibly hard on that. There's a thesis in my office that's a couple of inches thick, which shows a lot of failed experiments and toiling. I remember sleeping in the rat house overnight. He had the idea that I should measure the blood sugars in the rats throughout the day and throughout the night. So every hour I'd be testing the rat's blood sugar, and sleep and set a little alarm for every hour, and that left me kind of frustrated with research because things didn't really quite work out as I expected. But I'd put so much into it. So when I came to Alberta 25 years ago to come and train in liver transplant surgery with Norman Knietemann, I also asked if it would be possible to spend some time in the lab working again on the islet cell transplant. And very fortunately here, Ray Rajotte and his team had carried out extensive research in islet cell transplant, and I was able to learn a lot from them. They were able to help set up our laboratories for testing. And then all of a sudden the experiments that were so difficult to do in Newcastle began to work in Edmonton. That's really the beginnings of the treatment. When I was asked to run the program to treat patients, there wasn't a lot of interest at that time. There'd been around 240 people that had been transplanted in the world with islets at that time, and fewer than 9% of them had worked at a year. And they asked me to run this program, and from what I learned in the lab as part of a PhD and changes that we made from experience in clinical transplant practice, allowed us to come up with the Edmonton Protocol, implement it in patients, and all of a sudden, the first 7 patients that were treated were completely free of insulin. It was quite unexpected, and I don't think I was really prepared for that level of success so early in my career.
How we on this podcast talk a lot about success and how to practice success prior to that actually coming, like within your life. So how did that success feel, knowing that it was there? Like you were saying that you weren't prepared for that kind of success, but how did it feel once you 2020 hindsight and it all kind of reined in and you kind of accepted that success? Well,
this was a big one. We wrote up the results and I presented them at the American Transplant Congress, and then it became, as I say, viral. And the hospital switchboard at the University Hospital was choked with calls from desperate patients all over the world. Mm-hmm. I gave a presentation in Chicago to the Transplant Congress, 5,000, 6,000 people in the room. And I was, fairly junior. Nobody had ever heard of me. Yeah. And I gave this talk. It was in a plenary session. It was a room full of people. There were television cameras at the front, and the whole room gave me a standing ovation at the end. I was not used to that kind of attention. Yeah. And then when I came back to my office in Edmonton, there were literally thousands and thousands of calls and letters and desperate people wanting to get this treatment. But I would say I was pretty distracted, not by that, but by I'd only been in practice as a surgeon for a year or so, and I was at the beginning. I was doing a lot of doing emergency trauma surgeries and general surgery and liver transplants and pancreas transplants, and I didn't really know which way up I was. I was on so many call schedules and so busy that it was a little crazy. So this Edmonton Protocol thing, although it was important, there were a lot of other big distractions. So I would say things we worked hard. We had a good group. The secret was probably having a great team in place and being able to work with the hospital and the university to implement innovative ideas, and they were receptive to that. It was a real privilege to do that kind of work here.
That's fantastic. I mean, I think that speaks to a lot of the listeners in regards to being able to focus on that kind of success. You know what I mean? We get a lot of people writing into us saying, I get so close to the end, and then they basically fumble the ball or whatever it is, it's almost self-sabotaging, right? And so people like yourself who can show that you don't have to fumble the ball, you can make it and be fine with it and have such success, and then still be able to sit in front of that media and be able to almost entertain it. It's okay to be that way. You know what I mean? So I thank you for your insight, your personal insight on that. One of the other questions that came was, what would be preemptive measures somebody could do before getting diabetes, if there is anything? So what does I know we go, I guess, a lot into diet in this regard, but what would you suggest would be best preemptive measures?
Well, I think that it depends on if it's the autoimmune diabetes that affects the children, the type 1, or if it's the type 2. The type 2 diabetes is very much a lifestyle thing.
Okay.
So it's not always patient's fault. We always say, patient needs to lose weight, and it'll make a big difference. If they can lose weight, then they can sometimes cure themselves of diabetes. Sometimes people that have big weight problems can undergo the weight reduction surgeries, and in an instant, those can also cure patients of the type 2 diabetes. So there is, you're asking about prevention of diabetes. I think we need to look critically at how we live. How we shop, what we buy, what we eat. Our bodies are our temples, and if we eat badly, we set ourselves up for weight gain. And if we don't exercise well and regularly and adequately, then we set ourselves up again for the westernized disease of weight excess. And that's a big part of type 2 diabetes.
That's actually funny that we went there, because I confessed to the listeners, today's show that just came out, that I have a 44-inch waist, and my goal over Sober October is to be a 40-inch waist, if not a 38. I've gone from 360 pounds down to, I'm now 290. The biggest I was before this was 280 and went down to 180. So I have lost the weight before. I used to professionally fight, boxing and mixed martial arts, so on and so forth. But the biggest problem that I've always had, especially with fighting, was it was feast or famine all of the time. And so to find an actual diet that complements health and nutrition within my life, it's either carb crashing with meat, right, and very little vegetables. So now I'm trying this paleo diet right now, so that me and the listeners can kind of go on that journey over the next 30 days. Even on my Instagram page, I work out all the time. I have a 3 on 1 off schedule. I'm going to a 4 on 1 off schedule, pretty close to what my fighting schedule was. But now I'm not working out for a fight. I'm working out for myself, especially being in recovery. So I am a recovered addict after 5 years. So I've been recovered for 5 years. I worked on the addiction piece, but what I didn't work on was my physical health piece, right? And I didn't see how much that actually tied into my addiction as well.
Interesting, yeah.
So I'm starting to see that now, and being a Quebecer, so my family's from Quebec, we do have a higher instance for diabetes. Like everybody in my family is diabetic, and I don't want that. I have gone for tests to make sure that I don't have it. I still don't have it today, even though I am considered obese because of my size and my height. And I'm okay with that label. Like, I know a lot of people are like, we should get rid of that word obesity. And I'm like, you know what? That's the description of what it is that we have, right? Yeah. And so in saying that, I almost see, I'm 34 now. I'm fighting for a better life. I don't want to be 40 with diabetes. I don't want to be 38 with diabetes. And I think in Canada, the big consciousness that we have to have is, as much as healthcare is free, we're the ones who have to be the first line of preemptive measures in our life in order to not have to go to a doctor where it becomes, well, this is what it is, and this is where you're going to be going, right? And I think that kind of focus of preemptive measures is kind of missed in regards to, like, I don't mean the healthcare side. I mean us as Canadians.
Mm-hmm.
We as a society don't see that, or even Americans don't see that it's our responsibility and our obligation not to feed into like McDonald's and all of these fast food places. So, I mean, I like that you're saying it's the dietary piece, right? And it's interesting how that just came about with what we were talking about yesterday, and then here we are today.
Well, I
right?
say that because it's the part that's potentially in our control. You know, if we talk about weight, it's all about energy in and energy out.
Mm-hmm.
So if you take too much calories in and you're not burning them off, you're gonna gain weight. And obviously, everyone has different metabolism. Some people have more challenges with it than others. It's not like it's one person's fault.
Yeah.
But it is a big challenge to be able to change your lifestyle to adapt. So congratulations to you for taking that on. And
I hope I'm successful.
Yeah. Well, good for you.
Do you know of any nutritionists that kind of line up with some like I guess that do videos or whatnot that might be able to prescribe, or some type of reading literature that somebody might be able to get their hands on for nutrition?
That's not my area, so I'm more on the surgical and research side, but there definitely are. There's a huge body of literature on nutrition and diabetes. There are experts. We have world experts in nutrition at the University of Alberta. In fact, within the Alberta Diabetes Institute, Dr. Catherine Field is one of the world-leading experts in nutrition and diabetes.
Excellent.
And there's several others as well. So it's not my area to advise on that, but it's a very important area.
So if somebody can go and check out that doctor and see some of the stuff that she's written, it would be probably advantageous towards your health. A question that just kind of popped into my mind was, what is the most exciting thing that you've seen that could have had a potential development that just hasn't come to that point yet? Aside from the last study that you were talking about, that sounded very similar to genetic rewriting, I guess is what it was.
Well, we have several of those in the works, and that's so much. The reason I love research is, and also get frustrated with it, is you have to have many irons in the fire, because I would say 9 out of 10 things that we work on don't work out. But it's the reason we do this is it's the 1 out of the 10 that really does, to take the field forward. So I'll give you a number of examples. So in liver transplants, for example, that's a very complicated surgery, very complicated. And we've been taking out organs from brain-dead organ donors for the last 40 years. And we store them before we transplant them in an ice bucket that you could go to Canadian Tire, basically, and they're stored within a bag of ice and some preservation solution and kept cold. It's very primitive. It's very simple. It's very cheap, actually, but it's very, very, very primitive. Now we have a machine. Someone came up with the idea that, well, why don't you keep the liver alive outside the body, just the way as though it was inside the body? So instead of sewing the blood vessels directly into the patients to start with, sew them onto pipes that can be connected to a machine. And in the machine we pump blood, oxygenated blood, through the liver, and we give nutrition, and we give insulin, actually, and we give some other medications. And these livers look normal, they work, they make their bile, and we can measure all the parameters of function on the machine before we transplant the patient with that liver. Wow. And sometimes we have a liver that we're not sure about. It seems to be a good one, or maybe it isn't. Maybe we're putting the patient, if we put a liver in and it doesn't work, the patient will die. It'll be a big deal. So how can we test if the liver's going to work before we put it in? So if we put the liver in the ice box and we look under the lid and it's a cool liver, it's not working, you've got no idea if it's going to be a bad liver or a good liver. But if you put it on this machine and it's working normally, completely outside the body, then you know it's going to work in the patient. And we've done this now on, let's see how many, almost 50 people.
Wow.
So we're pretty excited.
That's pretty amazing.
Yeah. So we worked with a group in Oxford to test out this machine. It's called OrganOx, and the Oxford University team that developed it. and it's been very effective. It's going to change the face of organ transplant. So there's one example in liver. And there's, I can think of several examples in our research of things that we're working on. So another was a trial that we've moved to the clinic because it looked really good in mice using a really great compound called anti-aging glycopeptide, AAGP. It's the same kind of, it was found in Arctic fish as an antifreeze protein. So it stops the fish from freezing in the Arctic.
Wow.
And it was extracted from the fish, and then a synthetic compound was made, anti-aging glycopeptide. And it looked phenomenal for protecting the islet cells before we transplanted them. So we're now testing that in patients. There's another example.
Wow.
There's always something on the horizon. And another area was seeing if we could find a new place to put the islet cells instead of in the liver. So if we put the cells under the skin, they don't work. There's not enough blood supply to let them engraft. So in 2002, I was doing some experiments in the lab with the team, and we found that if we put a plastic tube under the skin for a month, we could, like if you had a slither or a splinter under the skin, what the body's natural response to a foreign tissue there is to make new blood vessels. That's the first, before it scars off, the first thing to do is make new blood vessels. So we were able to harness this foreign body reaction by putting the tube in, leaving it for a month, taking it out, then in mice, putting the islet cells in, all the stem cells, in that new area. And we turned an unfavorable site, the skin, into now a site that can accommodate the cells, and they work really well. So that's another one. So we're moving that forward into a clinical trial to test into patients, a deviceless transplant approach. So there's lots of things on the go, and
cool.
It is very cool.
Yeah, that's really, really cool. I'm blown away. I'm blown away by some of the things that are on the horizon. I think this is just a quintessential life on life's terms question. Where is it that you find your motivation and your drive to continue, like just to continue aside from seeing all these new innovations, but just something inside of you that keeps you pushing forward?
I see diabetes as it's a treatable, it's a potentially curable disease. All of the work that's been done for the last 40 years in mice and in rats, you make a mouse diabetic, you put the cells in, they're cured. And we've got proof of concept that when we do this in patients, the same thing can be achieved. And now it just seems like it's within our reach. There's a few more questions, a few more little things that need to be tweaked. And so what keeps me going is the knowledge that this can work. And all it needs is good ideas, determination, and testing, and really good international global collaboration between good scientists. And that's what we have. So trying to be, the one person leading, taking it forward on their own isn't the way forward. Mm-hmm. The way forward is to work as a global team.
Wow.
And we have some really good international collaborators that we work with and share ideas freely together. We're all of the same mindset that this is a disease that can be cured. And it's going to take some very simple steps to get from here to there.
It's almost like AIDS. We always thought that AIDS would never become something that was as treatable as it is today. And I think that's that's what we need to look at. Like everybody always says, oh, well, we'll never cure cancer. I don't believe that either. I think at some point, eventually that's going to happen because we've cured AIDS and in a relatively short amount of time.
In a very short time, again, with intensive global effort. And if you look at the other disease that look at the tainted blood scandal and hepatitis C. Mm-hmm. Hepatitis C was a big issue. And in fact, it was our commonest indication for a liver transplant just a few years ago. And all of us, and every time we do a liver transplant, if a patient had hepatitis C, there was a very high risk that when we did the transplant, the disease would come back and affect the new liver very rapidly. So sometimes within a matter of a few weeks, the liver would be blown out of there by fulminant cholestatic hepatitis that would destroy the transplanted liver. So we'd put all this effort into very sick patients, and then you'd see them basically fail from time to time. And then this treatment came along. The discoverer of hepatitis C works in Edmonton, and Lon Terrell and Michael have worked very closely together to work on new treatments for hepatitis C, and now this disease is cured. There's medications that are very expensive right now. It's not available for everybody, but in the last few years, since those treatments came online, we haven't had a single patient, or very few patients, put it that way, that still have active hepatitis C at the time of their transplant, and this was not possible a few years ago. So you're right. So AIDS can be cracked. There are there are medications, combination treatments now that will control that disease very well. The same thing with hepatitis C. It can be treated and eliminated very effectively. So diabetes, the same thing will happen.
And I'm sure you're asked this question often. This is really the last one. We're going to be rounding it out here pretty quick. This is from a listener, but they asked, what's the timeline, or do you think you'll see a cure of diabetes within your lifetime? Is basically what they're asking, if there is an actual timeline for it to be cured.
Well, the simple answer is yes. It's going to happen. I think that what I always hesitate on is not so much the lifetime thing, but it's the 5-year cure. Because I'm often asked this by mums and dads that have children with diabetes. Is there going to be a cure for my child in 5 years? And they have been promised and disappointed so many times. The hard thing from a scientist's point of view is guaranteeing a timeline, because even if we have something that looks really promising in the lab, and we have lots of things that look really promising, to move them forward into the clinic and then test them, prove that they work in patients as well as they did in the mice, and then show that they're safe, show that they're effective, and then find drug companies that will make them and move things forward. That all takes time, and sometimes things fall down because something works really well in a mouse, but when you try it in a patient, it's not as good. Sometimes things fall down because the drugs that you want to treat the patients with have never been tested before, so you have to do some normal volunteer controls or find some other information that shows that the drug is safe before you can move it forward in diabetes. So making a guarantee on time, because there's so many unknowns, and every time you do an experiment, there's always a higher risk that it will fail than succeed. I find it really hard, that issue of promising and not being able to deliver. So I don't like to do that. So
you had a couple of, I think the question was asked also at Google, and I kind of was expecting this answer, but this listener was very, very adamant that he wanted me to ask.
Right.
So I asked again. But this actually rounds us out. This is the show. I thank you very much for coming in. You're very prompt at replying to the email, and I hope your experience was good over this podcast. Maybe a potential for us to re-invite you back in a year or so, probably around Sober October. If I don't get this thing beat in about a month, maybe what we'll do is we'll come back and maybe have you in another year or so as a follow-up.
And good luck with your journey as well, Justin.
Thank you.
Very brave to do that, and it takes.
I think this is the craziest thing. Is at this moment it feels like you and I are sitting at this mic, talking, but there'll be about 150 to 300 people instantly tomorrow listening to this show. And by the end of the week, there will be about 8,000 downloads just on this show alone. So like, as much as it's just you and I, all of a sudden the perspective turns around like, oh yeah, there's a bunch of people out there listening to this thing, right? And they do hold me quite accountable on my Instagram. So again, I thank you very much for coming in.
Thank you, Justin. Great pleasure.
So shout outs are to Liam Connolly at Connolly Law for all of your Canadian law, will, estate, media issues. Google Liam Connolly at Connolly Law. He'll be happy to take care of any of your legal matters. We at Life on Life's Terms will have our t-shirts out by the end of next week. You can check that out at www.lifeonlifestermspodcast.com, and you can also visit us at our Instagram page, Life on Life's Terms Podcast, at Life on Life's Terms Podcast, and you will see a picture of Dr. Shapiro as well as the other guests who've been on this show. Hope you guys are having a wonderful Friday, and we'll talk to you soon. Bye for now.